Welcome to Parasitic Diseases. Today we're going to discuss aberrant nematode infections. That includes Toxocara canis and Toxocara cati. These are two ascarid nematodes. One infects dogs, the canis, and the other infects cats, the cati. These two infections are found throughout the world, and they're infections that are common among our pets, as well as in sylvatic animals that are both feline and canine. But mostly it's an infection of domestic animals. And as we'll see, we acquire this very easily from our direct contact with our pets. And it's a big problem that has yet to be fully solved. We have one person to thank for essentially raising awareness of the fact that this infection does exist in domestic populations, not just domestic populations, mostly in children. So it's a pediatric problem of major medical importance in many areas throughout the world. Paul Beaver was an icon of the middle 50s, 60s, and 70s research unit at the University of Tulane Medical School. He trained many, many graduate students, and a lot of them did their PhD theses work on various aspects of these two infections, both from a clinical, an epidemiological, or a biological aspect, working on the details of these infections. So without Paul Beaver's dedication to this particular subject, it would have taken us a much longer time to become aware of its significance. So the life cycle of this parasite is very easy to describe in the definitive hosts, which in this case are cats and dogs, because all I have to do is refer you back to the Ascaris life cycle for humans, and you'll get all the details for these two infections in dog and cat. These are Ascaris-like worms. They're a little bit smaller than the Ascaris worm that infects humans. Instead of being the size of a pencil, they're the size of a half-used pencil. The worms live in the small intestine of these two animals. They produce eggs, a prodigious number of eggs, just like the adult of Ascaris lumbricoides does in humans. And these eggs become dispersed in the local environment, wherever cat feces and dog feces are allowed to occur without being sequestered. So contact with the egg of this parasite with a dog or cat allows the worm to be ingested. The egg then hatches in the small intestine. The larva penetrates the wall of the small intestine and migrates via the blood to the liver. Remember, the worm then grows a little bit, eating parenchymal cells, etc. It then gets back into the circulation and makes it up into the lung fields where it gets stuck. It then penetrates out of the alveolus, migrates up the bronchi, across the epiglottis. The dog swallows or the cat swallows. The worms go into the small intestine where they develop further to adults. The adults mate, and the females then begin to produce eggs. And this life cycle takes about 3 to 4 months to complete, given the fact that the worm takes a long time to grow up in the small intestine. So what happens when human beings ingest these embryonated eggs in the environment? What happens to us? And so maybe the word life cycle shouldn't have been used to open up this session. Maybe I should say the reason why this is an aberrant infection is as follows. When humans ingest either the egg of Toxocara canis or Toxocara cati that has a larva inside, the egg is swallowed, it passes through the stomach, which stimulates the larva inside to produce enzymes, which it uses then to hatch out of the egg in the small intestine. The worm is now free in the lumen of the small intestine. It then penetrates the wall of the small intestine and enters the blood supply. And at that moment, it's as though you were driving down a highway and you saw a sign that said, turn left, and instead you turned right. This worm now is in a place where it is totally unfamiliar. Its biology does not tell it that it's in the right place. Why? Because it's in the wrong host. So the chemistry that we present to this worm after it enters our blood supply totally confuses the worm in terms of its biological purpose. The biological purpose, of course, is to pick up environmental cues that tell it it's now in the liver, and it's now in the lungs, and it's now once again in the small intestine. Those are the cues. We do not give off those signals to this parasite. So then what happens? Well, it becomes a wandering parasite. The parasite is small, it's microscopic, it's perhaps 70 or 80 micrometers in length, and this worm remains as a third stage worm and travels throughout all of the organ systems of a human. It can then emerge into tissues. Emerging into tissues, seeking a way out, basically, is where the pathology from this infection originates. And so if this worm penetrates into the lungs, for instance, there is a hemorrhagic event that occurs. There's a granuloma that develops. The worm may not be able to crawl back into the circulation. It may die at that place. A granuloma will then form around the worm. The worm will die. As it dies, it calcifies, of course. And imagine hundreds of these events throughout your body. If this occurs in brain tissue, something else occurs. The worm continues its migratory path into the brain tissue itself, and it can actually result in central nervous system symptoms and signs which could imitate a variety of other diseases. And so for many, many years, in aberrant infection with the larva of Toxocara, canis, and cati were often mistaken for other clinical diseases, which eventually were shown not to be true. If the parasite enters liver tissue, there might be some associated disease associated with larvae migrating throughout the liver. These are small organisms, and if a very few are present, not much damage would occur because the liver is such a large organ. However, there are some places where this worm, if migrating, ends up in a death of a worm. That tissue is such a sensitive tissue with regards to damage that we will instantly see a result of a clinical manifestation. And the eye happens to be one of those places, namely the retina. So larvae of Toxocara, canis, and cati can migrate to the eye, and they can then die at that spot. When they do, of course, a granuloma forms. One other thing happens as these worms migrate throughout the body, and that is, of course, the host starts to catch on to the fact that it's being invaded. Its immune system kicks in. It then places pressure on this worm. The worm experiences discomfort. Now, I can't honestly tell you what it feels like from the perspective of the worm, but I know that the worm has a nervous system, and the worm can detect its environment, and it can process information, and it can act on that information. The immune system alters the nature of that information. And what it actually does end up doing is force worms into tissues where those immune reactions are not occurring, namely the brain and the eye. So what starts out as something referred to as visceral larva migrans, as the disease progresses over time, let's say 2 or 3 months into the infection, it can switch to a disease localized just to the central nervous system, including the eye, at which point it now is referred to as ocular larva migrans, with serious consequences for the host. Now remember, this is a pediatric problem. So there's a lot of data collected by pediatricians, particularly from rural and suburban areas where kennels are very common and where lots of dogs are being raised for sale, obviously. These infections occur quite regularly at that point. I must tell you that one of the nuance of this infection that Ascaris does not share with this ascarid is the fact that if an adult dog happens to be female, and if she happens to be pregnant, these larvae can actually traverse the placenta and enter the pups during their embryogenesis. And when the pups are born, they can actually harbor viable adult infections of Toxocara. And this has confounded veterinarians for many, many years as to how this might occur, but nonetheless, we know that it does occur. and therefore preventing this infection has many, many levels of activity necessary to intercept the parasite, not only in the definitive host, but in the host's offsprings as well. Here are the adult males and females shown to scale. The male, of course, has a curlicue tail, as all nematode males do, or I should say most nematode males do. Females are more robust and bigger. And here is the embryonated egg. Unlike the ascaris egg, the outer coating of this egg is smooth, so it's easy to distinguish. It's common in soils throughout the world where you would look in, say, a park, an urban park like, say, Central Park or Hyde Park, or many of the other parks around the world. These surveys have been done on a regular basis, and a lot of eggs from Toxocara canis can be demonstrated in those soils. Remember, this is a pediatric problem, so lots of little kids are out there playing in those soils as well, and that explains the common way in which this parasite is acquired by humans. Now, when you look at the tissue damage that's done, it's all because of the third stage larva. These larvae can live up to 6 months and migrate to all kinds of tissues, but as I mentioned, when they migrate into the eye and they die, these large granulomatous lesions form. And this actually, if in the wrong place, the macula is shown right over here, if this lesion were to develop in this area here, or even in this area here, you would have ocular dysfunction. And now Dr. Daniel Griffin is going to give a clinical vignette illustrating the pathogenesis of this infection.
A nurse in her early 20s, recent graduate, who is now many months into her global health internship with the Foundation for International Medical Relief of Children, FIMRIC. She has a skin issue that is getting worse rather than better. She reports that on her foot, she has a skin. Well, I should say, initially she was told it was a fungal issue. So she says that she has a skin area. She was told it was a fungal infection, but despite topical antifungal cream, this is getting worse. Should be a little background. This is in a remote area of the Dominican Republic, right on the Haitian border. Now, a picture, they say, tells a story better than 1,000 words. So perhaps you can look, and I'm going to try to highlight what we're seeing here. You can see this raised red irregular serpiginous line. She reports that even though we're seeing it here, that this has been in different locations on different days and that this has been moving around. And she keeps putting the antifungal cream and it doesn't get better. And I will point out, because I think this is characteristic as well, there's a couple areas where there are vesicles, like small blisters. So fluid-filled raised lesions. So let's talk a little bit about clinical disease. I'm going to discuss about cutaneous larva migrans, visceral larva migrans, and ocular larval migrans. So let's talk a little bit about the clinical disease that we see in these three different categories. So cutaneous larva migrans. This is caused by the larvae of the dog and cat hookworms. So you'll have these slides, you'll be able to remember these, but Encyclostoma brasiliensis and Uncinaria stenocephala. Now, you can see less commonly transmitted nematodes, such as the raccoon-transmitted Strongyloides procyanus. This is your duck hunter's itch. And the story here, what is happening here? But the L3 larvae, the infective stage of A. brasiliensis, survives in the sandy, moist soils for several days. This is basically, you've got a dog, they're on the beach. It's a cat hookworm. There might be a cat, but the classic story is a dog is on this beach. They have defecated. Little time has gone by where the larva is now at the L3 infective stage. The unwitting host lays down, is enjoying the sandy beach. They don't lay a towel. They just lay right there on this beautiful beach. This is not a tourist beach where they're raking it and cleaning it and keeping the dogs away. And then what they end up is the L3 larva is going to penetrate the unbroken skin. And then it's not going to have the right enzymes to allow it to penetrate deeper. And so it's going to end up migrating laterally in the deeper layers of the epidermis. And this is going to occur for about 10 days. Now, during this 10-day migration, you're going to get an intense inflammatory reaction. It's going to become quite itchy. And you're going to see these serpiginous lesions, which really are the worms aberrantly migrating through the deeper layers of the epidermis. It's quite disturbing. It's itchy. It's aesthetically frightening for a lot of individuals. And if you scratch too much, you've always been told by your mom, don't scratch. Maybe your dad tells you that too, hopefully. But if you scratch too much, you can actually end up with secondary bacterial infections, which can be a significant problem. Let's move on now to visceral larval migrans, right? So this is going to be in the viscera. These are going to be different organisms. These are going to be the ascarids, but not human ascarids. So it's going to be your Toxocara canis and your Toxocara cati, right? So these are ascarids that are similar in life cycle to the human ascarids. So you can think you're going to be ingesting these. So you're going to start by ingesting these in. And then you're going to end up with this visceral migration where these are going to be migrating through the viscera. And there's a lot of concerns and controversy here. There's evidence that during this time of covert disease, while there's migration going on, you can end up with breathing problems, so pulmonary dysfunction, but you also can end up with cognitive impacts, even potentially developmental delays. So there's a big controversy, concern, discussion about how much of this is going on and how many children are disadvantaged by this exposure. This is only going to last for weeks to months while the migration is occurring, because ultimately the larvae are going to die. You're not going to get a completion of the cycle because they're in the wrong host. So when you're seeing kids who may have these cognitive deficits, it's going to be repeated exposure. And unfortunately, the dead and dying larvae could actually end up in the lungs, the liver, the brain, and it's the dying larvae where we're going to see the significant immune response. So eosinophilic granuloma is a hypersensitivity type response. But what about the eye? Now, this is the same syndrome, but the ascarids could actually end up migrating to the eye. So you're going to see the same life cycle, the same story, except the larvae can end up in the eye. And in the eye, they can develop granulomas. If it's in the wrong place, you might get some loss of vision. But one of the historic concerns was people not being aware of this, thinking it was a retinoblastoma and actually having a child lose an eye unnecessarily. So unnecessary surgery, when someone responds to this, or the granuloma itself being responsible for the loss of sight. Diagnosis. Now, there is serology. There's an ELISA that's available from the CDC. And it's somewhat sensitive. It's not great. It's only about 80%. Reasonably specific if you use the right cutoff. So you want to be thinking about epidemiology here. But direct visualization, the ocular larval migrans, you can actually diagnose on an ophthalmological exam. And then histology, larvae can be seen in tissue sections. What about treatment? Now, we don't have a lot of evidence to guide this, but the recommendations are albendazole, available in the US, 400 milligrams POBID. This is for about 5 days. And when you have significant ocular inflammation, steroids have been suggested as a therapy to add. Now, what about our patient? Now, our patient took albendazole, 400 milligrams POQ day for about a week, and noted that things resolved. Patient did well. And actually, the response was pretty quick. As I discussed, it's only going to be 10 days before this will probably self-resolve because they will die. But with the albendazole, basically within 24 hours, there was no more migration occurring, and so rapid improvement.
Now, the best way to try to keep this infection out of the pediatric population is to try to separate the worm from the patient. And we do this in several ways. For rural areas, it's probably not possible to keep feral dogs and cats away from the environment, of course, and since there aren't too many people that take advantage of those situations, this may not be an important factor there. But for domestic, suburban, and urban environments where sandboxes and playgrounds are common, it was often thought that the sandbox was the source for this infection, and in some cases it actually was. because dogs, when they defecate, the feces remains essentially where the dog puts it. Whereas cats are much more fastidious. Perhaps it's a way of disguising where they've been, because cats are more secretive. They're more sylvatic than dogs, let's put it that way. So if cats defecated only in sandboxes and not dogs, then I think there may not be as big a risk, because the cat will bury their feces. Well, you could argue also that kids will just dig them back up again as they play in the sandbox, so that's probably true. So the best way is to prevent the cat from defecating in the sandbox to begin with. And so these vinyl covers that have been designed to cover over these play areas have been very successful in some places, particularly in Japan. Then another approach, of course, is to take your pet to the vet. And the veterinarian will then, of course, do a stool exam, find the eggs, and say, your cat and dog, they've got Toxocara. You say, but, this pup was born from a mother of a family of dogs that I was familiar with. And they said, well, the organism can actually traverse the placenta. So this dog need never have gone outside in order to catch this infection. Albendazole is an effective treatment. And so routine treatment with albendazole is the way to keep this infection out of our pets and therefore out of our children as well. Unfortunately for us, there is another example of an ascarid infection. This case, it's an infection of raccoons. And raccoons are found throughout North America. They're not found in Europe. There is another animal there called a raccoon dog, which may also act as a host for Balis ascaris procyon. But in North America, certainly the raccoon is the definitive host. And raccoons are peridomestic. They derive most of their opportunities for establishing colonies and for obtaining food by living next to people. And people actually find raccoons very endearing. They are very social animals. They're domesticatable. You can actually train these animals to come feed at your doorstep every evening. And there are lots of YouTube examples of families of raccoons which have been adopted by people. Little did those people know that these friendly little intelligent animals may be harboring an ascarid parasite, which produces an egg that then gives rise to a larva that's twice the diameter of Toxocara canis or Toxocara cati. Not only is it twice as large, it's more aggressive in terms of its migratory behavior. So if someone acquires this infection, and it's rare, I must say that it's rare, but in many cases that have been documented in the clinical literature, where a fatality has resulted from a visceral larval migrans episode, they have all been caused by Balis ascaris procyon. And you can see here is a cross-section of brain tissue, and you can see the larva of these large nematode larvae in the tissue. And they're quite damaging in terms of their migratory behavior. The diagnosis for this infection is made by biopsy, which is, of course, clumsy and chancy. The statistics are not in favor of making the diagnosis this way, but given the fact that you have no other explanation for why this child suddenly became ill and started to exhibit central nervous system behavior aberrations, making this diagnosis based on that gives some reason for doing a biopsy and looking for the organisms. Whenever they were discovered, high doses of albendazole were tried with very few treatment successes, unfortunately. Elimination of this infection means eliminating the raccoons from our peridomestic neighborhoods. We also know that raccoons are very commonly the source of an outbreak of rabies as well. So getting rid of raccoons wouldn't be a bad thing, but they're very clever animals, and they're hard to get rid of because their only behavior is in the evenings, where they live during the daytime. Most people are not aware of those sites, so they are well adapted to life among humans without being detected, basically. Now, there are two other parasites that I'd like to tell you about. They're known as brainworms. Now, these brainworms, Angiostrongylus cantonensis and Angiostrongylus costaricensis, are found in two different places. As their names imply, cantonensis is found in Asia, and in the Philippines, whereas Costa Ricensis is found primarily in Central America, and of course Costa Rica is the epicenter for where this parasite can be found. They are sylvatic infections mostly. They mostly infect rats, and the rats are the definitive hosts. They acquire their infection by ingesting eggs. The worms then develop in the tissues of these animals, and they migrate throughout the tissues using lytic enzymes to do so. They enter the bloodstream and go into the lumen of the small intestine, where they are carried from the body out with the fecal mass. That's where the eggs go. The adults, however, live in some very interesting places, unfortunately. One of them lives in the arteries surrounding the brain. And that's the one that has become synonymous with brainworm infections, because we've had a recent outbreak of this infection in the United States. And it's traceable back to accidentally eating the infected intermediate host, which turns out to be a variety of mollusks and crustaceans. In this case, slugs of various kinds can become infected with the intermediate stages of the infection. The rats become infected by eating the slugs that are infected with the larvae of Angiostrongylis, and the slug is a normal food item for many rats and many rodent species throughout the world. Now, when human beings ingest this parasite through accident, let's talk about Cantonensis first. The larvae become swallowed, of course. They hatch in the small intestine, they enter the bloodstream, and they eventually end up in the capillaries of the meninges, where they die. This elicits a granuloma, and the granuloma becomes surrounded by eosinophils, and the condition is known as eosinophilic meningitis, and the symptoms are mild and short-lived. One would think they would be more severe, but they're not. However, the Costa Ricensis version of this infection produces something that's more acute, but fortunately for us, these worms do not locate to the brain. Rather, they go to portions of the small and large intestine, and that's where the eggs are produced, because it produces a viable infection in humans. But the signs and symptoms are greatly reduced, as I said, compared to the Cantonensis infection. A history of eating raw or freshwater shrimp often leads to the diagnosis with regards to Costa Ricensis, and as a result, treatment is then instituted, but it's mostly of a supportive nature. We really don't have a good drug to address this infection. So until one is found, we will simply have to treat the symptoms until the worms die in the tissues. Gnathostoma spinagirum is an aberrant infection in humans. This nematode infects a wide variety of hosts, including cats, dogs, mongoose. The adult females lie within the walls of the small intestine, where they lay eggs. The eggs pass in the feces. Feces have to enter fresh water in order for the cycle to continue. They hatch and are ingested by a wide variety of macroorganisms, shrimp, crayfish, etc. It's kind of reminiscent of the same scenario that occurs with Capillaria philippinensis. The larvae infect these animals and then are eaten by a wide variety of predators, snakes and fish. The cats and dogs eat these larger prey species and become infected with the third stage larvae, which then develop to adults, lie in a nodule inside the small intestine where they start to produce eggs and complete the life cycle. Humans become infected in an aberrant fashion when they ingest raw fish. Now, raw fish eating is fairly common among humans. We like our sushi, but we usually don't eat freshwater fish as sources of sushi. It's mostly freshwater fish, or saltwater fish that we eat. So eating a freshwater fish that's perhaps a tropical version of some dish that's reminiscent of a sushi dish that you would ordinarily get in Japan or in China or in the United States, in places where saltwater fish solely are used, everybody wants to be fashionable. And so these freshwater fish have been introduced as a source of sushi as well. But the result, of course, is that occasionally there are large outbreaks of nassostomiasis that results from the ingestion of the third stage larva that lives inside the muscle tissue of the fish. The worm doesn't go on to complete its life cycle in humans because we're an aberrant host. It could migrate to the deep tissues. It could end up in the eye or the brain and cause symptoms associated with infection in those organs. Making this diagnosis is very difficult, although if you're familiar with the epidemiology of the infection and there's a case history of eating raw freshwater fish as a source of sushi, may lead the physician to make the correct diagnosis. Then the treatment can be instituted either with albendazole or ivermectin, with good results. And finally, there's a series of infections that are caused by the ingestion of, in this case, saltwater fish, eaten raw, either in sushi or in other preparations like green herring or pickled herring or brined herring, in which the larvae of ascarids, these are ascaris infections now, of seals, orcas, a variety of whales, sea mammals basically. And those life cycles occur by the adult worms living in the gut tract of those definitive hosts. The eggs are passed into the ocean. They're ingested by a wide variety of small intermediate hosts. And those little intermediate hosts are then filtered out and eaten by a wide variety of predator species. And in this case, the predator species happens to be either whales, etc., orcas, seals. And when they eat those intermediate hosts, they acquire the adult infection again. So it's an ascaris life cycle between the whale or, let's say, sea mammals and small invertebrate intermediate hosts, which could, however, become ingested by fish. They will not obviously change the stage of the infection, so that if, let's say, a crustacean becomes infected with the ascaris of a whale ascarid, the crustacean is then ingested by a fish. That third stage larva remains as a third stage larva. Now it's in the fish, and the fish is then eaten by, let's say, a seal. The seal will acquire the infection this way. So you can pass these larvae along, and they will remain as larvae until the definitive host eats them. And that's where the problem lies, because we harvest a lot of saltwater fish for use in sushi restaurants throughout the world. And in Europe, there's a lot of herring that's ingested, that's rarely cooked. Mostly it's pickled. So that we have the option of acquiring this disease, which is now generically called anisakiasis, where the third stage larva, situated in the muscle tissue of a fish, now is digested away from its host tissue, and it encounters us. And so what happens at that point is that the worm tries to find a way out because it now suddenly realizes it's in the wrong place. And in trying to do so, of course, it penetrates the wall of the stomach, and it causes an acute abdomen syndrome, which could be misdiagnosed for a wide variety of other things. But early on in the growth of the sushi industry, this infection was quite popular throughout the world in terms of the diners experiencing a wonderful cuisine and then going home and complaining because of an abdominal discomfort, which in many cases would just go away after a couple of days. But enough people got sick so that they went to their gastroenterologist. The gastroenterologist looked, and much to their amazement, they see these whitish and red-colored worms sticking out of the wall of the stomach, and using a gastroscope and an extractor can actually pick these animals out and examine them and send them off to a laboratory for identification. And many of them turned out to be the third stage larva of the adult worms, which would locate in the gut tract of whales, seals, orcas, etc. And that's how the history of this evolved. So that today, we find very few infections in humans from exposure to living third-stage larvae in these tissues. Why? Because we've learned how to cope with this. We can't avoid the infection in these fish because it's part of the harvesting process of catching the fish to begin with. So what do? We deep freeze the tissue. We flash freeze it in liquid nitrogen. And in doing so, and then thawing it back out again, the tissue remains essentially unaltered in terms of texture, but the worms inside that tissue that would have caused us a problem are now killed. So in many, many, many places throughout the world, we find this practice. And so we see that represented here. I'd never heard of this dish before. Magist herring is prepared in a specific way. The process of gibbing, which I'd never heard of, and I'm sure Alton Brown might not have heard of it either, but nonetheless, the gills and the intestines are removed, but the pancreas of the fish is left intact. Perhaps it's because it gives a specific flavor to the herring as it matures, as it ferments, I should say. Then the herring is salted for about 5 days, and just before salting, it's frozen for at least 24 hours at minus 45 degrees C to kill all the possible parasites. Now, this is a quote from I guess gibbing is the verb also, to how do you gib a herring. And indeed, if you don't have liquid nitrogen, I would recommend don't try this at home. If you want to learn more about the effects of Toxocara canis and Toxocara cati on children through clinical studies, there's a very good systematic review of the literature that this is a reference for. We've also discussed Toxocara on several episodes of TWIP. You can access TWIP at microbe.tv/TWIP. Next time, we're moving on to an entirely different group of worms, the segmented flatworms or tapeworms. Thanks for listening.